been doing. And the question that I would like to put to him is, reaching zero-dose children in India's huge urban and peri-urban slums especially remains one of the most persistent and complex challenges. Okay. So what are the specific barriers that you have seen in your experience, whether they be geographic, social, or even systemic, that make this setting so difficult to serve? And what are the technical and social innovations that you have been doing that, broke through some of these difficulties? So if you can briefly describe some of the challenges and ways of breaking through them.
Thank you, Dr. Sarkar. So it is based on one of our programs called Sakhi, which we have been running for last 5 years in number of urban slums. So if we talk urban slum, it is one of the most complex geographies because it is heterogeneous. We have people coming from different parts of the country.
Right.
Most of them are poor, right? At times they don't even have their ID cards. They are migrating because of livelihoods, and at the same time, it is a very dense, dense clusters. And moreover, the infection rates are more because there is a mixing of water and sanitation and sewage. So it is a very precarious. It's like an atom bomb, which can explode anytime. And poverty is also, as they come for all the livelihood. But at the same time, for example, if we talk of a Mumbai or talk of Maharashtra, for example, urban slum in Thane, there's even a barrier of language. People are coming from UP, Bihar in search of livelihood, and the system works in Marathi. So it is again a barrier. Apart from that, there, obviously, the routine vaccine hesitancy, misconception, myths are always prevalent, but it is all added by the social demography of the community. And then the absence of data. For example, in one of the programs, we found that while working in clusters, there was one cluster which was even not identified by the government. Everything was unknown at all, and we had to find those clusters. So in order to work in those communities, we have for example, in Maharashtra, the health system speaks in Marathi. We have health workers who speak Marathi. So and the communities are for UP, Bihar, they speak Hindi and Urdu. So how to bridge the divide? So we were able to find intermediary health workers as transgenders, which are the kinders. We trained them, recruited them, trained them, and believe me, they are one of the best public health communicators I have seen in my last 25 years. If they are trained well, they do wonders. Also, they have a high rate of inclusion. They don't discriminate, based on gender, caste, religion, nothing. So it's a fantastic community.